Hi friends, today I will talk about ECG changes in left ventricular hypertrophy. First is the disclaimer. This video is made for educational purpose only and there is no endorsement for any brand or the company. Uh, for diagnosing left ventricular hypertrophy in the ECG, we have to follow two criteria. First is the voltage criteria and second is the non-voltage criteria. Among the voltage criteria, the most commonly used method is Sokolov Lyon criteria. Here we add the depth of the S wave in V1 with the tallest R wave in the V5 or V6. If their sum is more than 35 mm, then it suggests left ventricular hypertrophy. But this voltage criteria must be accompanied by a non-voltage criteria for considering as a diagnosis of left ventricular hypertrophy. Various other voltage criteria are, we can find these voltage criteria in the limb leads and the precordial leads. In the limb leads, if the R wave in lead 1 plus S wave in the lead 3, if it is more than 25 mm, or R wave in the AVL if it is more than 11 mm, or R wave in AVF it is more than 20 mm, S wave in the AVR if it is more than 14 mm, then these findings also suggest left ventricular hypertrophy. In the precordial leads, if R wave in V4, V5 or V6 if it is more than 26 mm, R wave in V5 or V6 plus S wave in the V1 that is more than, if their sum is more than 35 mm, that is, this is a Sokolov Lyon criteria. And another one is the largest R wave plus largest S wave in the precordial leads if it is more than 45 mm. These are all voltage criteria, whether they are in limb leads or in the precordial leads. But the most commonly used method, which is usually chosen by the most of the physicians, is a Sokolov Lyon criteria, that is the sum of S wave in V1 and R wave in V5 or V6. If it is more than 35 mm, then it is partially suggestive of left ventricular hypertrophy. But this voltage criteria must be accompanied by a non-voltage criteria, and the non-voltage criteria is when there is increased R wave peak time, that is more than 50 milliseconds in lead V5 or V6, or if there is ST segment depression and T wave inversion in the left-sided leads, that is lead 1, AVL, V5, V6. This is also called the left ventricular strain pattern. So voltage criteria plus non-voltage criteria like increased R wave peak time more than 50 milliseconds in V5, V6, or if there is ST segment depression in T wave inversion, that is left ventricular strain pattern in the left-sided leads. If both these criteria, voltage criteria and non-voltage criteria, are met, then these findings are suggestive of left ventricular hypertrophy. If we see the pathophysiology of the left ventricular hypertrophy, the left ventricle hypertrophy is in response to pressure overload, which is secondary to conditions such as aortic stenosis and hypertension, and this results in increased R wave amplitude in the left-sided ECG like lead 1, AVL, V4, V5, V6, and there is increased S wave depth in the right-sided leads, that is lead 3, AVR, and precordial leads like lead V1, V2 and V3. The thickened left ventricular wall also leads to prolonged depolarization, which leads to increased R wave peak time and delayed repolarization, which leads to ST and T wave abnormalities in the lateral leads, that is strain pattern in the lateral leads. When we find the LVH changes in the ECG, the additional ECG changes can be seen, and these are left atrial enlargement, left axis deviation, ST elevation in the right precordial leads, that is V1, V2, V3, but this will be discordant to the deep S wave, and prominent U waves, that is proportional to the increased QRS amplitude. In this ECG, we can see that this ECG suggests left ventricular hypertrophic changes. As we can see the voltage criteria, the depth of the S wave in V2, and if we summarize, add it to the R wave in the V5, V6, it is more than 35 mm. And the non-voltage criteria is the LV strain pattern, that is ST depression, and T wave inversion in the lateral leads, that is V6. These both voltage and non-voltage criteria together helps in the diagnosis of the left ventricular hypertrophy. Causes of the left ventricular hypertrophy, most common causes are the two very important causes, the hypertension and the aortic stenosis. But aortic regurgitation, mitral regurgitation, coarctation of the aorta, hypertrophic cardiomyopathy, they also contribute to the left ventricular hypertrophy. This is the complete list of the causes of the left ventricular hypertrophy, but remember that most common causes are the hypertension and the aortic stenosis. We should always remember that the only voltage criteria is not enough to diagnose the left ventricular hypertrophy. This voltage criteria must be accompanied by a non-voltage criteria, and if these two criteria, voltage and non-voltage, they suggest only that patient may have left ventricular hypertrophy, but to confirm that we must do the echocardiography of the patient. The patients of the left ventricular hypertrophy are usually asymptomatic, but they may present with chest pain, dizziness or syncope, or palpitation, fatigue and shortness of breath. This is an ECG which shows left ventricular hypertrophy. If I zoom it up, we can see there is marked increased LV voltage changes. We find the large R wave and S wave that overlap with the adjacent leads like SV2. If we add SV2 and RV6, it is more than 35 mm, and there is the R wave peak time. This is more than 50 milliseconds in V5 and V6 with associated QRS widening, and the LV strain pattern with ST depression is also seen in the this ECG. And if we see this ECG, there are we can see there are wide QRS voltages, and the S wave in the V3 are so deep that they are literally falling off the page, and the ST elevation in V1, V3 is simply in proportional to very deep S wave, that is the appropriate discordance. The LV strain pattern is seen in the all leads with positive R wave, that is V5, V6, lead 1, 2, 3 and AVF. So just to summarize, left ventricular hypertrophy, the main reasons are pressure overload states like hypertension, aortic stenosis, volume overload states like aortic regurgitation, mitral regurgitation, wall abnormalities like left ventricular aneurysm, hypertrophic cardiomyopathy, dilated cardiomyopathy. Besides ECG and echo, we can the left ventricular hypertrophy can be seen in some X-rays. The left ventricular hypertrophy will be seen in PA view of the chest X-ray, as the left border will be displaced leftward inferiorly and posteriorly, and there will be rounding of the cardiac apex. Two important signs can be seen in some patients, and they are Hoffman-Rigler sign and Schmoo sign. Hoffman-Rigler sign is seen on the lateral chest X-ray. It is basically the distance between the left ventricular border and the posterior border of the inferior vena cava. If this distance is more than 1.8 centimeter at a level that is 2 centimeter above the intersection of the diaphragm and the inferior vena cava, then it is suggestive of the left ventricular hypertrophy. So it is calculated from the distance between inferior vena cava and the left ventricle. Second sign is the Schmoo sign. It is basically taken from a old comic picture which was very popular in 1940s. Here we can see prominent left heart border and dilated aorta, which corresponds to the Schmoo's body and head. The picture given below shows Schmoo sign, and the above picture is suggestive of Hoffmann-Rigler sign. This is the chest X-ray suggestive of lateral and the downward displacement of the cardiac apex. Similarly, the echocardiography, to confirm left ventricular hypertrophy, we have to do the echocardiography. It is very specific test. There will be increased left ventricular internal and diastolic diameter if it is parasternal long axis LVIDD, if it is more than 5.3 cm in females or more than 5.9 cm in males, then it is suggestive of left ventricular hypertrophy. And also there will be elevated left ventricular volumes, diastolic volume more than 100 ml in female or more than 155 ml in female, and systolic volumes more than 49 ml in females, more than 58 ml in males, and there is increasingly spherical morphology. These all findings will also be suggestive of the left ventricular hypertrophy. Similarly, the CT scan, it also increases the specificity. Its specificity is 100% and sensitivity is 78% when the maximum luminal diameter of the left ventricle is greater than 5.6 centimeters. So to conclude, the main causes of the left ventricular hypertrophy are hypertension and aortic stenosis. These are the pressure overload states, volume overload states like mitral regurgitation, aortic regurgitations. They also contribute some cardiomyopathies. They also contribute to the left ventricular hypertrophy. In ECG, we can see these changes. We have to consider two criteria, voltage criteria and non-voltage criteria, to make a diagnosis. In voltage criteria, the most commonly used method is Sokolov Lyon method, and with this we have to take into consideration non-voltage criteria also, that is R-wave peak time more than 50 milliseconds or LV straining pattern. This is not the if ECG shows these changes, this is not confirmatory that patient will have a left ventricular hypertrophy. To confirm that, we have to do 2D echocardiography. I think this is enough to make us clear in mind about how to interpret an ECG with LVH changes. This is all. Thank you very much.